open the room for the delegates to join, sir. So, sir, it's already 6:30. Are we
Yeah,
good to go now?
yeah.
Thank you, sir. So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good evening and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online event hosted by the Society of Oncoanesthesia and Perioperative Care, and the focus of today's session is acid-base disorders in oncological ICU. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Sohan Solanki, sir, the Honorable Secretary of SWAPC, to start the event today with his enlightening words and for the further coordination. So, over to you, sir. Kindly proceed.
Yeah, thank you very much. And I welcome you all today to this 55th SOPSI webinar series we are doing and nowadays like once in 2 weeks. So it is this 55th session now. And for today's session, we have a special topic, acid-base disorder in the oncological ICU. So it is basically the acid-base disorder in the ICU. So for this topic, we have renowned like intensivist and anesthetist Dr. Atul Kulkarni, who is professor and head of intensive care unit at Tata Hospital, Mumbai. And he has a vast experience in intensive care, so many books and so many publications. He is also the editor of the Indian Society of Critical Care Medicine. So I think he's the best person today to chair this session. So without wasting time, I give over to Atul sir. Atul sir, now the like mic is yours.
Hi, good evening. We are going to discuss acid-base disorders, which is a very, very vast topic and extremely important for managing any patient, be it intraoperative period or in the perioperative period, or once they go to the ward and come back to the ICU for treatment of any other complications. And the initial steps, apart from the ABC, involves assessing and treating the patients for acid-base disorders. The another corollary for that is patients who get chemotherapy or radiotherapy, they have poor intake, they are malnourished, and therefore they also are very, very prone to various dyselectrolytemias. And all of this will be hopefully covered in today's session. And Dr. Snigdha from Kamineni Institute of Medical Sciences will be speaking about this. She's assistant professor currently in the Kamineni Academy of Medical Sciences and Research Center. And she's the first fellow of SOPSI. So please welcome Snigdha and let us hear from her. All yours, Snigdha. Please proceed.
Sure, sir. Good evening, all. Thank you for the kind introduction, sir. In the initial part of my session, I shall cover the basic concepts of acid-base disorders, and later I shall proceed to the various acid-base disorders that we encounter in our setup, oncological setup in specific. So Arrhenius was the first who laid the foundation stone for acid-base chemistry. An acid was defined as a proton donor and base as a hydroxyl ion donor or a proton acceptor. The concepts of acid-base disorder are mainly based on three laws: the law of electrical neutrality, law of conservation of mass, and dissociation equilibrium. The law of electrical neutrality states that in any compartment in an aqueous solution, the amount of positive charges should be equal to the amount of negative charges. The law of conservation of mass states that in a compartment, the amount of a substance at a point of time remains constant, and it only changes when we add the substance, remove the substance, degenerate it, or destroy it. The third is the law of dissociation equilibrium. Now we have the concept of buffer systems here. A buffer is anything that resists the change in pH. We have extracellular and intracellular buffers. Among the extracellular buffers, bicarbonate buffer system is the most abundant. And we also have the phosphate and ammonia buffer systems in the extracellular compartment. In the intracellular buffer systems, we have hemoglobin, proteins, and phosphate buffer system. The most abundant among the intracellular buffer systems is the phosphate buffer system. There are various analytical approaches which are used to analyze the factors that change the pH. Now we have the descriptive or Boston's approach, in which bicarbonate buffer system was considered as a factor which influences the pH. It was considered as an independent factor to influence the pH. Later came the semi-quantitative or Copenhagen's approach, in which unmeasured anions were also taken into apart from the buffer systems. But still, the bicarbonate was considered as an independent entity to influence the pH. Later came the Stewart's approach, in which they proposed that strong ions are the main factors which influence the pH apart from the bicarbonate buffer system, and they considered that bicarbonate buffer system is a dependent buffer system. That is, the bicarbonate levels change within change in the strong ions, and it only forms a dependent system, not an independent system like the strong ions. Later in 2016, we had the quantitative or simplified Stewart's approach, which is also called the Davis-Torrey approach. This is very relevant to us in our setups because we usually encounter patients with mixed disorders due to various factors which influence the acid-base balance in the body. Like we have patients with metabolic acidosis, alkalosis, high anion gap or normal anion gap, metabolic acidosis or alkalosis, compensated or uncompensated. With the help of Davis-Torrey approach, we can quantify the factors which influence the pH. Now, before going with the analytical approaches for acid-base disorders, we should have in mind the presentation of the patient first, whether the pulmonary, any gastrointestinal symptoms that the patient has, any signs of infection, neurological conditions which may lead to diabetes insipidus or SIADH presenting as an acid-base disorder, any cardiac conditions if the patient is pregnant or the patient has taken any medications which influence the acid-base disorders, any intoxications. And in our setups, we need to know about the post-chemotherapy status, the chemotherapy drugs the patient is on, whether it's an induction therapy or the previous history of chemotherapy of the patient, and other surgical history in our patient population. Now, all starts with the alteration in the dissociation of water. Water has a pH of 7 at room temperature of 25 degrees. Now we add some ions like the cations, anions, unmeasured ions, which results in a change in this pH. Now we have the normal pH that we know has a range of 7.35 to 7.45 due to this. When there is an insult to the body, like there are some toxins that are produced because of the altered metabolism, because of the insult, it results in an increase in the anions, which results in metabolic acidosis. And a disturbance in the PaCO2 results in a respiratory disorders. So on the whole, the pH is influenced by PaCO2, the total concentration of weak acids, and the strong ion difference. The initial concept, that is the Boston's approach, is from the Henderson's-Hesselbalch's equation, and it says, as I've stated before, that bicarbonate buffer system, which is a independent factor to influence the pH. Now the pH is influenced with the PaCO2. If the pH moves in the opposite direction with that of PaCO2, it is primarily a respiratory disorder. If the pH and bicarbonate moves in the same direction, then it is primarily a metabolic disorder. Now the body has an insult, so it tries to compensate for it. So we have to look for the compensation by the body, whether it's a compensated or an uncompensated acid-base disorder. Now, these are the factors which tell us whether it is compensated or uncompensated. So, from these factors, we can see that the body reacts better if there is a metabolic acidosis. Like the factor is more when there is a metabolic acidosis. Later came the concept of anion gap, that it's not only the bicarbonate, but because of the increase in the amount of unmeasured anions, there is a metabolic acidosis. So as we can see, the anion gap is the difference in the concentration of sodium and potassium with that of chloride and bicarbonate ions. The normal anion gap is from 12 to 12 plus or minus 4 millimoles per liter. We see patients with high anion gap metabolic acidosis, the main causes being lactic acidosis, ketoacidosis, renal failure, and intoxications. In normal anion gap metabolic acidosis, the main causes would be gastrointestinal loss of bicarbonate, renal losses of bicarbonate, and ammonium chloride ingestion. Next came the concept of mixed disorder, where we have the delta ratio or the gap ratio. To simplify it, when the gap ratio is 1, it is usually a high anion gap metabolic acidosis. If it's less than 1, it is high anion gap with a normal anion gap metabolic acidosis. And if it is more than 1, we have high anion gap with metabolic acidosis with metabolic alkalosis. Here, I would like to mention about the patients with multiple myeloma, where we have a low anion gap, that is around less than 3 millimoles per liter. This is mainly because of the cationic proteins that we see in these multiple myeloma patients. So the chloride ions are absorbed, which result in order to counterbalance this unmeasured cations, leading to a low anion gap at presentation in this patient population. Later came the Stewart's approach, which is mainly based on the law of electrical neutrality. Here, they have used the Gamble-Gram to explain the acid-base disorders. They have put all the cations into one cylinder and all the anions into one cylinder. The major player among the cations is sodium, along with potassium, calcium, and magnesium. The major player or the miselectrolyte is the chloride, along with albumin and other unmeasured anions with bicarbonate ion. Now, in this approach, we see that bicarbonate is a dependent anion which alters with the concentrations of this independent anion like chloride ion. Now, in critically ill patients, we usually see hypoalbuminemia. When there is hypoalbuminemia, in order to maintain electrical neutrality, the concentration of the bicarbonate ion increases, resulting in a contraction alkalosis. Which masks the metabolic acidosis or other disorders that is present in this patient. So the patient may present to us with a mixed disorder. If there is an increase in lactates and ketones, it results in a decrease in the bicarbonate ion concentration, resulting in a metabolic acidosis. Now, from this graph, we can see that when there is a decrease in the strong ion difference, it results in metabolic acidosis. Whereas when there is an increase in the strong ion concentration, it results in metabolic alkalosis. This is the simplified Stewart's approach or David Story approach that was put forward in 2016. It is a quantitative approach. Now, we try to know the factors which cause the base excess or deficit in the body. Like the normal sodium concentration that was taken in this approach was 140 and chloride is 105. The usual difference is 35. The difference is more than 35. That is calculated as an entity. Later, the normal lactate level was taken as 1. Any difference or increase in the lactate level was then calculated. The effect of albumin on the base excess was also calculated. 0.25 is the factor which helps in converting the albumin to its ionic equivalence. Apart from that, the base excess or deficit due to other ions was also measured. So based on the number that we get, we were able to quantify the effect of each of these factors on the base deficit or excess. In this approach, like the Stewart's approach, strong ion difference and total weak acids were considered as independent factors to influence the pH. Apart from that, changes in the pH and bicarbonate were taken as secondary to the strong ion difference or weak acids or both. By knowing the influence of each of these entities on base deficit or excess, we can correct the specific cause which causes the acidosis or alkalosis. So let's start with the respiratory disorders that we encounter in the ICU. Now we have a patient with slow and shallow breathing. The patient is mainly hypoventilated, resulting in a respiratory acidosis. The problem mainly we encounter, the problem may be a central cause. So in our setups, we usually see the patient with residual opioids or on excess benzodiazepines or propofol, which this is mainly seen in palliative setups. So when we encounter a patient with rapid and shallow breathing, the main causes may be peripheral. So it may be a neuromuscular cause like residual paralysis, high epidural or spinal anesthesia, like thoracic reasons like pneumo or hemothorax, or VQ mismatch that we see in one lung ventilations, or abdominal splinting that we see in upper abdominal surgeries, retained secretions, or atelectasis. If we encounter a patient with obstructed stridor, then it may be because of airway issues or an obstruction at the supraglottic, glottic, and subglottic level, or a bronchospasm resulting in a respiratory disorder on an ABG. Later, next we'll go with the metabolic acidosis. When we encounter a patient with metabolic acidosis, we first look for the anion gap, whether it's a normal anion gap or a high anion gap metabolic acidosis. The various etiologies for normal anion gap metabolic acidosis that in our setup would be renal tubular acidosis or bicarbonate losses that we see in a surgical ICU, like in conditions of diarrhea or ileostomy, pancreatic drainage, NaC, using sodium chloride for solutions for resuscitation, and bladder reconstruction surgeries. Here I would like to emphasize on the bladder reconstruction surgeries. Usually ileum is used as a conduit to reconstruct the bladder. The mucosa, the bowel mucosa here has the propensity to increase more, to absorb more of bicarbonate ion. So when the acidic urine enters the reconstructed bladder, it increases the propensity of the bowel mucosa to more absorb the bicarbonate, to more absorb the bicarbonate. So it results in a hyperchloremic, hypokalemic metabolic acidosis. So in order to balance this, we usually give the sodium bicarbonate or low doses tablets. Now, when we talk about high anion gap metabolic acidosis, we look at the lactate level. If it's more than 2, this may be a cause for the increase in anion gap. So there are type A and type B lactic acidosis. We will discuss about them later. And we also look at the serum creatinine levels. If it's high or the patient is having a low urine output, then the renal acids may be a contributing factor to the increase in the anion gap. Then we look at the blood glucose and urine ketone levels to look whether diabetic ketoacidosis, alcoholic or starvation ketoacidosis is the reason for this metabolic acidosis. So if the blood glucose is high and urine ketones are positive, usually it points towards DKA. If the blood glucose is normal and urine ketones are positive, it may be a starvation ketoacidosis. I would like to mention about the alcoholic ketoacidosis. Here, beta hydroxybutyrate is more predominant than acetone in alcoholic ketoacidosis. So beta hydroxybutyrate is not detected by the lab parameters, and acetone is only detected. So we may have that we may have a low blood glucose with a urine ketones negative, but an acidotic picture in alcoholic ketoacidosis. Next, we talk about the serum osmolality in a patient with metabolic acidosis. If the osmolar gap is more than 10, it implies that the patient is intoxicated. When we try evaluating a patient with lactic acidosis, we look at various factors like SVO2, CVP, and stroke volume. Now, if the SVO2 of the patient is less than 70% with a CVP of less than 5 and a stroke volume of less than 0.7 mils per kg, it is usually a circulatory insufficiency or a type A lactic acidosis. First, we check for the hemoglobin. If the hemoglobin is low, it is likely to be a hemorrhagic shock. And we look for the bleeding source. And mainly in our conditions, we look for hidden sites like an intra-abdominal cavitary bleed or a retroperitoneal site or a GI tract. For this, in order to look for the hemorrhagic shock. Next, we look if the hemoglobin is normal, then we check the total leukocyte count and look for the inflammatory markers. If they are high, it implies that the patient may have a septic shock, and we look for the source. If the TLC is also normal, then we run an echocardiography and look for causes of low ejection fraction or a cardiac tamponade and try to correct it with inotropic and IABP support and drainage if there is a cardiac tamponade. Now, when we have a patient with SVO2 more than 70 with a CVP of more than 5 and stroke volume more than 0.7 mils per kg, it is usually a type B lactic acidosis that may be because of an impaired oxygen extraction ratio and various other reasons. Now we consider poisoning in these patients like use of previous use of metformin, sodium nitroprusside, cyanide, or carbon monoxide, endogenous or exogenous use of epinephrines, and we also look for conditions of liver failure or mitochondrial failure, which in late stages of sepsis. In this stage, there is impaired oxygen extraction in these patients. If nothing of this is possible, then we consider a regional hypoperfusion. We look for all the peripheral pulses. If there is no peripheral pulse, we consider an arterial thrombus there, do an angiography and revascularize it. And if there is no peripheral pulses, then we consider a visceral ischemia, like a bowel or splanchnic ischemia, evaluate and treat it. We also encounter patients with renal acidosis in our ICU setup. This is because of the decreased ability of the kidney to excrete the excess amount of acids. So we try to bridge this renal acidosis with soda bicarb or sodium acetate, or we consider a dialysis or THAM. Now, about THAM, it is a proton acceptor and it generates ammonium ions without generating CO2 in order to decrease the amount of protons, and the end product is excreted by the kidney, and it does not increase the sodium load like in case of alkali therapy or use of soda bicarbonate. A few words about alkali therapy. The bicarbonate that we use, it's not an effective buffer. It has a pK of 6.1 and it acts in a pH range of 5.1 to 7.1. Now, if the bicarbonate has to work effectively, it should be used in a pH less than 7.1. It also has adverse effects like increase in CO2 load and sodium load on the kidney. The concept of intracellular acidosis by use of bicarbonate is debatable. This is the formula that we use to calculate the amount of bicarbonate that can be given to a patient. So we try to correct the bicarbonate till 15 and leave the rest to the body and try to correct the cause of the acidosis rather than correcting the bicarbonate in number. When we talk about metabolic alkalosis in ICU setups, there are two types of metabolic alkalosis: chloride responsive and chloride unresponsive. The most common that we see is chloride responsive metabolic alkalosis. It is usually seen in patients with vomitings, nasogastric suction loss of protons, or bicarbonate gain or ingestion of the bicarbonate, and resulting in a loss of volume. The treatment is saline infusion and maintaining the fluid balance. The chloride unresponsive metabolic alkalosis is very uncommon. It is basically because of mineralocorticoid excess or severe hypokalemia, extreme hypercalcemia, or severe magnesium deficiencies. We usually encounter these electrolyte imbalances post-chemotherapy in our patient population. So the treatment would be to correct all these electrolytes and use of acetazolamide SOS. Now, when we talk about acid-base disorders in oncological setups, we should also consider the dyselectrolytemias that happen because of the chemotherapy, post-chemotherapy status, which also leads to the acid-base disorders. So we have the tumor lysis syndrome, and we know occlusive diseases caused due to allogenic hematopoietic cell transplant, and differentiation syndrome due to acute promyelocytic leukemia, resulting in a fluid overload and causing a metabolic acidotic picture. We also have the platinum drugs, which cause hypomagnesemia, hypocalcemia, hyponatremia, and hypokalemia through various mechanisms, resulting in the acid-base disorders. Now, SAIDH is a presentation that we see with alkylating agents, vinca alkaloids, and tyrosine kinase inhibitors, resulting in hyponatremia. Now, another very specific thing, that is hypochloremia, resulting in metabolic alkalosis, is seen in diarrheas caused due to the tyrosine kinase inhibitors like afatinib, erlotinib, and gefitinib. Well, let's discuss some of the clinical scenarios that we encounter in our ICUs. A patient with a nasogastric suction tube, what happens is the removal of the chloride ions without the sodium ions. It causes an increase in the strong ion difference, resulting in a hypochloremic alkalosis. We treat it by maintaining the fluid balance with normal saline infusion. We also encounter patients with diarrhea and ileostomies, resulting in loss of potassium and chloride, which results in a decreased strong ion difference and a metabolic acidosis. We treat it by maintaining the fluid balance with balanced salt solution in this condition. In patients with intracranial tumors, we usually encounter patients with diabetes insipidus, where there is loss of free water resulting in a contraction alkalosis. The treatment would be to use low sodium solutions like half NS and 5D, and use vasopressin and desmopressin. Use of diuretics is very common in ICUs. Now, when we use a diuretic, there is a net loss of free water more than sodium and chloride loss, resulting in contraction alkalosis. Hence, we need to use the diuretic judiciously and de-escalate it as and when unnecessary. Sodium chloride infusion or normal saline infusion is usually used in the ICUs. It is usually used in the ICUs, which causes a but now we have shifted to balanced salt solutions, because when we use a sodium chloride based solution, it results in a decrease in strong ion difference, resulting in a hyperchloremic acidosis. It also have other adverse effects like renal vasoconstriction, decreased GFR, and splanchnic hypoperfusion. Hence, our practice has shifted towards balanced salt solution, which have a more alkaline pH that is very near to the blood milieu. When we have patients with ileostomy and pancreatic drainage, it results in decreased SID, resulting in hyperchloremic metabolic acidosis. The treatment for this would be to maintain fluid balance with sodium acetate based solutions like plasmolite. In surgeries where there is a major fluid shifts or a massive blood loss, we use the blood products with citrate as a buffer, with the citrates, and we also use TPN with acetate and also lactate based solutions. So in this, what happens is that these buffers are cleared by the liver or metabolized by the liver, resulting in a selective increase in the sodium ion, which results in an increase in the strong ion difference. And if this is not corrected, it results in a hypoventilation and CO2 retention. CO2 retention. Hence, this chloride sensitive alkalosis needs to be corrected. The treatment for this is using chloride rich solutions like potassium chloride and calcium chloride. Now we have all these various hyperosmolar solutions which result in increase in free water like mannitol, alcohol, in conditions of hyperproteinemia like in multiple myeloma, which results in dilutional acidosis in our patient population. Hyponatremia is one of the most common electrolyte abnormalities seen in cancer patients. The most common cause for hyponatremia in cancer patients was seen as SIADH, and the tall and vaptans are considered to be tolerant in this, were well tolerated in patients with hyponatremia. So there are various mechanisms by which we can see hyponatremia in cancer patients because of true volume depletion in causes like hemorrhage, diarrhea, vomiting, drainage of ascitic or pleural effusion, peritonitis or ileus, or salt wasting nephropathy. And There may be an increase in total salt and water content with an associated decrease in effective circulatory volume, which is usually seen in malignant ascites, drug-induced congestive heart failures, severe liver diseases, hypoalbuminemias, and veno-occlusive diseases. We also see pseudohyponatremia in patients with hyperproteinemias. Hypernatremia is another factor which influences the acid-base balance in the oncological ICU. The main causes for this include ifosfamide-induced nephrogenic diabetes insipidus or amphotericin-induced nephrotoxicity. When we talk about hypokalemia, the various mechanisms involved in hypokalemia are like inadequate dietary intake, like in patients of malnutrition, redistribution of potassium that we see in alkalosis or uptake of potassium by tumor cells, extrarenal potassium losses like in radiation enteritis or villus adenomas, and renal potassium losses in ACTH secreting tumors, Benzjohn protein tubular toxicities, and hypomagnesiemias. Pseudohypokalemia is seen in marked leukocytosis. Hypercalcemia is another condition which may alter the acid-base balance in our patient population. The mechanisms involved include humoral hypercalcemia, the cause being a secretion of PTH-related protein, and metastatic diseases which result in increase in PTH-related proteins and other inflammatory markers like interleukin-1, 6, and TNF-beta, and increased gastrointestinal calcium absorption because of increased production of calcitriol by various tumors. Here, I would like to emphasize the importance of acid-base imbalances in various oncological emergencies. They may present in metabolic acidosis most commonly, but also with alkalotic disorders. I would like to make a specific mention of tumor lysis syndrome here, which is mainly seen in leukemias and lymphomas post-induction therapy. So it usually presents with hyperuricemia, hyperphosphatemia, hyperkalemia, and hypocalcemia, as we know, or partly with any of this electrolyte abnormalities. The management here includes a hyperhydration and use of allopurinol prophylactically 3 days before chemotherapy, which is continued for 2 weeks, or use of rasburicase, which converts uric acid to allantoin, which is excreted by the kidney. And we also have to manage the electrolyte abnormalities involved in the tumor lysis syndrome. A specific mention about lactic acidosis in malignancy. We usually see these in patients with aggressive tumors or Hodgkin's disease, acute leukemias, and sarcomas. The lactate level here parallels the disease activity. It usually resolves with the start of the therapy. The mechanism involved in lactic acidosis of malignancy is overproduction by the tumor cells or decreased hepatic clearance. We also see D-lactic acidosis rarely in colonic cancers. So now about D-lactic acidosis. The human body usually produces L-lactate. Now D-lactic acidosis is produced by the gut bacteria. When there is a subacute intestinal obstruction, like in conditions of colonic cancer, it results in a translocation of this gut bacteria, resulting in a D-lactic acid acidemia. The lab usually measures the L-lactate levels. So D-lactic acidosis cannot be measured by the lab. So we have an ABG with an acidosis, but the lactates are not elevated in this condition. Concluding, when we see a patient with acid-base disorder in ICUs, first we need to know whether it is a respiratory or a metabolic disorder, whether it's compensated or uncompensated, or a mixed disorder. Look for the anion gap. It's a high or normal anion gap acidosis, and look for the gap-gap ratio if it's a metabolic acidosis. Go with the simplified Stewart's approach in order to quantify it. Like it is very relevant to our setup with major surgeries, and keep in mind the chemotherapy status of the patient. Look for the baseline ABG of the patient in order to look for things like lactic acidosis and malignancy. Thank you.
Thanks, Snigdha. I don't see any questions there. Sohan, is it all right if I give some comments about this?
Yes, sir. So meanwhile, the people write the questions. You can take the discussion, then you can ask or whatever, or you can give comments, sir.
Okay, so right now there are no questions. I had several comments. Okay, so there was a study about, so apart from THAM, there was a study of, there was interest in dichloroacetate for treatment of metabolic acidosis, particularly lactic acidosis. And this interest has been around since 1970s, I think. So there was a study published in NEJM in 1983, where they treated patients with lactic acidosis using dichloric acetate. And it was not a randomized control trial. It was a simple study, just an observational or interventional study in 13 patients. Subsequently, in 1992, NEJM published another study with treatment of lactic acidosis, which was a placebo-controlled trial using dichloroacetate again. And what they found was that there was no difference, or there was non-significant difference in the lactic acid levels in the placebo group as compared to the dichloroacetate group. And there was no effect on either the pH or the hemodynamics or the mortality. So treatment of lactic acidosis as a number without treating the cause will not improve the patient's outcome regardless of the approach that we take. That is something that we need to remember. The other thing that I noted was that people use alkalinizing therapy using soda bicarb in patients with acidosis. And I agree with Snigdha when she said that it is debatable whether it causes intracellular acidosis or not. However, many studies seem to recommend it without any actual experimental basis and say that because in acidic medium the vasopressors or the catecholamines don't work well, maybe we should give bicarbonate in these patients. There seems to be use of soda bicarb even in patients with ARDS. If you look at the ARTSNet study, that study in the protocol recommended that if the pH of the patient, because of respiratory acidosis, dropped to less than 7.15, you can give bicarb infusion. I don't know how that could overcome the problem, because you will end up producing more carbon dioxide and actually worsening the problem. About the Stewart approach or the Levitt story approach, the Stewart approach is slightly more complicated. The worst part is that you have a really complicated formula and you actually need an online calculator to use this. And we actually published a study in 2022, if I remember correctly, where we compared the Stewart's approach to the albumin corrected regular approach or to acid base disturbances. And we found that there were no additional disorders that could be found if we use the corrected approach. So the usual approach is fine. Stewart approach is probably useful for patients who are going to be using using this for research purposes mainly. Before we go on to the use of balanced salt solution versus normal saline, I think there are a couple of comments or questions. So, Snigdha, do you want to answer this question? How to validate a blood gas, arterial blood gas? Is she there or?
Yeah, I'm there, sir.
Yeah.
Sir, we validate an ABG by using like we use the Henderson-Hasselbalch's equation. Like we see whether the bicarb, like the pH correlates with the bicarbonate. Like I am not sure how specifically, but the basic is the Henderson-Hasselbalch equation that we use to validate an ABG.
Yeah, so basically you check the pH and you check the H ion concentration.
Yes, sir.
To validate whether, so that should be your first step before you go on to analyze. The second question again by Sudipta, is how to approach combination acidosis alkalosis using gap analysis.
Sir, as I've stated in the slide before, like we look for the anion gap excess and the bicarbonate deficit. That is the gap delta ratio or the gap ratio. From that, we determine the ratio. If it's one, it is usually a high anion gap metabolic acidosis. If it's less than one, it's a combination of high with normal anion gap, and if it's more than one, it is a combination of high anion gap metabolic acidosis with a metabolic alkalosis, sir.
Okay, he wants you to speak a few words about negative anion gap.
Sir, I've stated it. Negative anion gap, low anion gap, I have stated, sir, in multiple myeloma patients. Negative anion gap is usually we see it we usually analyze the urine negative anion gap. I don't know about the blood negative anion gap, sir.
Sudipta, can you explain what you mean by the negative anion gap? Can you speak, Swan?
Yes, sir. Yes, sir.
Is the audience able to interact by speaking, or they can only type?
No, sir. They need to type on the chat box.
Can you explain further what you mean by the negative anion gap? Besides that, I would like to make a comment about the hyperchloremic acidosis because of use of normal saline and Ringer's lactate. So there or the balanced salt solution. So whether we should be adopting balanced salt solution in our practice routinely. So should we stop using normal saline? So many people say that normal saline is actually not normal. It should be called abnormal saline because neither the pH nor the tonicity matches exactly the that of plasma. If you trace back the use of normal saline and how the hyperchloremic acidosis was described, you will trace it back to a study, or I could trace it back to a study in late 80s or early 90s, I think, where in patients who were undergoing hysterectomies, the authors gave them about 6 liters of fluid. Now, by no stretch of imagination, someone undergoing a hysterectomy should receive 6 liters of fluid. And this happened in both the arms, and they said that the patients, when they are given normal saline, they develop hyperchloremic acidosis. Now, there are two things about the hyperchloremic acidosis. One is hyperchloremic acidosis develops. So the question is, so what? I mean, does it really affect the outcome? And we actually don't know the answer. There was a study in 1996 or 97 published in Critical Care where they retrospectively looked at all patients who had a bicarbonate uh, uh, which had decreased by more than 2 millimoles per liter. And then, therefore, they said that these patients are hypo or acidosis, and then they divided them into various types of acidosis. So, except for lactic acidosis, none of any other type of acidosis actually led to mortality of the patient. Now, this was a very old study, and I don't think there has been any study which has looked at just acidosis and the outcomes of the patient. However, we know for sure that lactic acidosis itself causes mortality. I'm not sure whether hyperchloremic acidosis itself causes mortality. However, the biological rationale is there. So when you present a large chloride load to kidneys, there is immediate vasoconstriction of the afferents, and therefore the like Snigdha mentioned in her presentation, that there is immediate decrease in the renal blood flow leading to a drop in glomerular filtration rate, and therefore there is a chance that the patient will develop acute kidney injury. Unfortunately, again, we don't have comparative studies. There was a before and after study which was published in about 2005 in the ICU patients. This was not in the perioperative period. This was ICU patients where they looked at two periods. One period where the clinicians were allowed to give whatever fluid they required or they wanted to prescribe. In the second period of 6 months, the clinicians had to specifically ask for either normal saline or 3% saline, and they had to justify the use of this saline. So essentially, you're looking at two periods where in one period they were allowed to give whatever amount of chloride they wanted to give, and in the second period they could not give chloride without justifying its use. And in the period where the chloride use was restricted, and I think this was published in JAMA, they found that the incidence of patients requiring renal replacement therapy because of AKI was higher. The studies so far of use of balanced salt solution versus normal saline given in appropriate quantities, which means that suppose you want to resuscitate someone, the surviving sepsis guidelines recommend 30 ml per kg fluid bolus initially, followed by normal saline or crystalloid. It says now crystalloid, it doesn't say normal saline. Initially, it used to be normal saline. So 30 ml per kg, if you keep on giving normal saline, obviously, you will get metabolic acidosis, which will be the type hyperchloremic acidosis. The problem with this approach is which one of us actually in our private practice use only one type of solution for all the patients all the time. You will look at the sodium, you will look at the electrolytes, you look at the chlorides, and then only infuse solution. The last study that was published from US called the SMART trial and the SMART ED trial, they say that there was no difference in outcomes, but the balanced salt solution that they used in their study in about 90% patients was Ringer's lactate. So if you want to be on the safe side, by all means use balanced salt solution, but there is no need to use expensive balanced salt solution. Ringer's lactate is an excellent balanced salt solution which does not cause any harm. So there is only one contraindication to the use of Ringer's lactate, and that is patients with hepatic failure where the lactate metabolism is hampered. Otherwise, there have been studies in patients undergoing renal transplant. There have been studies in patients with severe metabolic acidosis where Ringer's lactate was used for resuscitation without affecting the outcome of the patient. That's about it. I don't see any more questions there. So, Sohan, back to you, I think.
Yes, sir. Sir, I just want to ask a question to Snigdha, like how frequently we see the hypophosphatemia in the ICU, and like what are the incidence of things and how we mostly correct hypophosphatemia in ICU?
Sir, hypophosphotemias we usually see in malnourished patients, sir. As we know, phosphate is basically an intracellular molecule more than an extracellular molecule. So we usually advise like hypophosphatemia when the patient is like chronically for more days, like he has a prolonged stay in ICUs, or he is having any kind of bowel immotility, which may be like hypophosphatemia may be a cause for this. So usually, and we also see for the phosphate levels in hepatectomy cases, like it is used for the regeneration of the hepatic tissue. So if we usually try to keep the phosphate levels around 2.5 to 3 mg per kg, slightly higher in case of in post hepatectomy patients. And if there is a hypophosphatemia, we try to correct it by using POTFOS, which has potassium. And if the patient is on a semi-solid diet or something, we use sachets, sir, pot for sachets.
Yeah.
Mohan, I have a slightly different take than Snigdha on this. Uh, so hypophosphatemia is much more common than we think, primarily because, at least in the ICU, apart from what Snigdha says very rightly, that patients who are malnourished or patients who are underfed for whatever reason will have hypophosphatemia. Any patient who has stayed in the ICU for a couple of days or more without being enterally fed is a sitting duck for developing hypophosphatemia. The reason for that is that we do not routinely monitor phosphate. That is the most important reason. And what happens is that because we keep concentrating on the sodium and the potassium and the calcium, we sort of neglect to measure phosphate. How often do you measure the phosphate levels in your patients routinely? So in our ICU, we do phosphate almost daily, and the incidence of hypophosphatemia in our ICU is quite high. So I remember out of 6 or 7 patients today in ICU, 3 patients were on potphos infusions. So unfortunately, we have only potassium phosphate available in India. In other countries, Europe and Australia, we had also sodium phosphate available. So if the potassium was low, we would use potphos to correct the potassium and the phosphate levels. If the potassium level was normal, then we would use sodium phosphate. And I don't know what the problem is, because I have talked to the neon people repeatedly. They are the people who manufacture the potphos, I think, for manufacturing also sodium phosphate. Because if sodium phosphate is available, we will use it very, very routinely. The other thing that you would remember, and I'm sure Snigdha forgot to mention it, she knows about it, is the refeeding syndrome. And that is because of the hypophosphatemia that we have, and suddenly when you give a enteral load, then the patient manifests with the symptoms of refeeding syndrome. Snigdha, you want to talk about refeeding syndrome a little bit? It's okay, but it's so hypophosphatemia. I just wanted to correct the impression that hypophosphatemia is uncommon. It is not uncommon, particularly if you are dealing with patients. So perioperative patients are generally elective, who have undergone elective surgery, are generally not badly nourished. Patients who develop complications, say, or some patients who have undergone colonic surgery, where the surgeons don't like you to feed them immediately post-operatively, and they would insist that you put these patients on TPN, for example. These patients will develop hypophosphatemia because the TPN doesn't contain phosphate. So you have to give additional phosphate. Many patients with sepsis and septic shock, you tend to withhold their feeding, thinking that, I mean, there is evidence to suggest that it is not mandatory for you to treat or give feeds immediately to these patients. So early versus late feeding as late as 1 week is okay. And people are scared to give enteral feeds to people who are on vasopressors because of the fear of inducing bowel ischemia or perforation. And these are the patients who tend to develop hypophosphatemia, which we tend to ignore. Does that answer your question, Sohan?
Yes, sir. Thank you, sir.
I do not see any more questions there. So I think
If anybody have more questions, please write in the chat box. We have 7 minutes more to go. sir,
Sorry, yeah, go on.
sir, can we have the like conditions like where actually that lactate value is normal or maybe below normal, but your liver is still very bad or like something like that, like liver is not something like body is not able to produce the lactate. Can we have this type of conditions ever in the ICU?
Low lactate is normal perfusion?
Yes, sir. No, low lactate in like hypoperfusion or in the like in a very bad liver disease.
No, but then lactate will accumulate. You will actually have high lactate. You will not have low lactate. You will have.
So that I understand, sir. But can we have the conditions like this where the like even even if the liver is bad, but the lactate values are normal?
I have not. I don't recall seeing such a patient. I don't. Unless you have seen on some occasion. Please enlighten me. I don't see. I don't.
Okay, I was just wondering about some.
Bad. Who has got a very bad liver, permanent hepatic failure, and normal lactate? No, I don't recall seeing any such.
Okay, sir. Yeah. So I don't think that there are more questions. So I think we can end our session here. So thank you, Atul sir, for a wonderful discussion on this topic, and thank you, Snigdha, for a detailed presentation of the this topic, and all the listeners who are here today evening to join this session. And so I give back our session to our trainer person. So please, Prituparna, you can end the session now.
Thank you so much for inviting me for this.
Thank you, sir. Thank you.
Thanks, Snigdha, for a very good presentation.
So thank you very much, dear doctors, for sharing such valuable insights. I hope you had a seamless experience. So with all your permission, we are signing off for today and looking forward to host you again soon in another interactive session in the near future. So till then, stay safe and healthy and have a nice day. Thank you very much, sir, for extending us the opportunity to host the session. Goodbye. Take care,
Thank you.
everyone.
Yeah.
Bye
Thank you, sir. Thank you, sir. Thank you, ma'am. Thank you, everyone, for joining us. So we are signing off.